is delivering healthcare in a retail setting, which is really innovative. And Walmart and Walgreens, for example, are proposing some really, really disruptive ideas. Unfortunately, Amanda can't be here. She actually came down with COVID earlier this week and is not feeling well, so I hope she recovers. Walmart is doing some exciting things in terms of delivering primary care, where you can see exactly how much different services cost and get them at clinics at Walmart. Walmart is also pioneering where they will pay for your college to become a nurse practitioner. So they will address the shortage of nurses who are going to deliver care in the Walmart clinics. So this is just rethinking how we deliver healthcare in America. So you don't have to go to the big hospitals and pay the big copays. You could pay directly at Walmart. And Walgreens is proposing some really innovative, disruptive ideas as well. And we are lucky to have here today with us Ed Kaleta, who is VP of US Government Relations for Walgreens. And he can talk about some of what Walgreens is planning in terms of delivering healthcare in a primary care in a retail setting, as well as I think some thoughts about government regulations around licensure, which is continuing the topic that Dr. Feldstein just talked about. So Ed, are you there?
Yes, I am, Dan.
Wonderful. Yeah. So if you share a screen, if you want to share your slides.
Great. Can you hear me okay?
We can hear you.
Great.
And see you.
Just looking for my slides here. Give me 1 second. They popped up earlier.
No worries. So your president and CEO, Richard Ashworth, has some connections to our School of Pharmacy, but now he's moved on to a new job, I see.
That's right. That's right. He is at Tivity.
Yes.
But I worked very closely with Richard, and he was a great leader for our business, and frankly, he was an outstanding advocate on behalf of pharmacy.
Yes, indeed. Okay, we can see your slides, so it's...
Great. Well, listen, thank you for the opportunity. Appreciate being able to chat with you all this morning. I'm going to go through a couple of slides here, try to give an overview. Many of you, I'm sure, are either living in Wisconsin or the surrounding areas and hopefully have a fairly decent understanding of Walgreens, but I think it would be helpful to walk through just a little high level about Walgreens. Then we're going to talk a little bit about the evolution that Walgreens continues to go through in order to frankly help serve our patients in as many different ways as they would like. And that includes consumerizing healthcare. For another day, there's actually if you track back, actually Walmart's the best example. Walmart tried to do a doc in the box, as it was known now probably 20 plus years ago. And unfortunately, that model back in the late 90s of having a medical doctor in a Walmart location, it didn't take. And it didn't take for two reasons. One is that folks at that point were really going to Walmart to buy cheap toys, dog food, and a bunch of other things, but they weren't interested in going to Walmart to get their health care. In addition, it was very expensive to have a medical doctor inside a store seeing patients on a full-time basis. You fast forward to 2020, and now you see all kinds of different arrangements, including what Walmart's doing, including CVS, of course, has a model based on nurse practitioners. And what I'm about to share with you is what Walgreens is looking to do, both from a medical doctor standpoint as well as from a pharmacist standpoint. So with that, just to give you all a sense, we have roughly 9,200 stores around the country. We do have the most stores of any pharmacy around the country. CVS is a close second at about 8,700 stores, including CVS pharmacies inside of a number of Target stores. We have 28,000 pharmacists that serve our patients. We interact with 8 million patients a day, but we have 88,000 healthcare service providers. So that is pharmacists, pharmacy techs, medical doctors, nurses, and a number of other folks that are all helping to interact with our patients. We have 230,000 employees nationwide, most of whom are actually in the 9,200 stores. And for last year, 2019, we filled 1.2 billion prescriptions. In addition, as we look at the future of healthcare and the best way to try to serve the nation's population, we believe that our footprint combined with what we can do online is going to be extremely effective. The last quote statistic I would share with you is that 78% of the US population lives within 5 miles of a Walgreens or a Duane Reade. Those of you that are from New York or have traveled there will know that we actually still own the Duane Reade stores, but they actually kept the name. So with that, I'm not going to spend a lot of time on this slide because I'd actually like to finish hopefully a little bit early and try to get to a couple of questions. I think you all are studying what is going wrong currently with the healthcare system, and there are a number of issues. Number one, it's too expensive. Number two, you get variable quality, cost, and experience. And number three, in a lot of ways, there's limited access. There's been a lot of discussion recently about underserved communities around this country and medically underserved communities. And typically when folks hear that, they think of rural parts of the country that don't have a doctor or don't have this type of healthcare provider. But what that also points to is urban areas, downtown Chicago, downtown New York City, Miami, Los Angeles. There's a number of large cities in this country that actually are medically underserved because there's not enough healthcare providers based on the population to serve them. And that's where we believe Walgreens can serve a significant role. We want and continue to strive to become the neighborhood healthcare destination. We'll be doing that through pharmacy, of course. We have different pieces on the retail, and we're going to talk today about healthcare services and then some of the patient and consumer services. I wanted to just highlight real quick that we have made great progress even recently. You'll see a number of quotes here from the Secretary of HHS, Alex Azar, as well as the Assistant Secretary for Health right now, Brett Giroir, who actually is in charge of testing for this for HHS. And then also, for those of you that are familiar with Health Affairs, which is a very well-respected journal, there was recently an article by a group of folks at Avalier that talked about how important it would be to have pharmacists be able to practice to the full extent of their license. That includes conducting and then also ordering and conducting COVID tests. And we'll talk a little bit more about what we are doing right now, but why we still need a legislative solution to help recognize pharmacists as non-physician providers under Medicare Part B. A number of pharmacies have stepped up during this pandemic, and there's a lot of things that we're now able to do because of emergency orders that this administration, governors, state Medicaid programs around the country have been able to make happen. But they're on an emergency basis, and most of those will end once the pandemic ends. It's our goal to be able to demonstrate that all the things we've been granted authority to be able to do during this pandemic, that those should be made permanent so that pharmacists continue to provide all of the services that we are during the pandemic. I think you all are also, I would just mention that, there's a number of academic journals that have done studies, and we have very significant savings that pharmacists are able to demonstrate to the program, to patients and to the healthcare programs around the country, whether it's Medicare, Medicaid, commercial and payers through employers. There's a lot that pharmacists are able to do. What does pharmacy need? Pharmacy needs increased scope of practice, and that is essentially allowing pharmacists, again, to be treated as non-physician providers under Medicare Part B. We also need increased scope of practice at the state level in order to be able to be doing more things than just putting pills in the bottle. We need enhanced technology and automation in order to allow pharmacy techs and pharmacists to be doing things in a way that hasn't been envisioned until the last couple of years. For example, a pharmacist at one store should be able to supervise other pharmacists at other stores within a certain mile radius. In addition, pharmacy techs should be able to take on more responsibility under the supervision of a pharmacist. Those are things that had never been envisioned, and now many realize that that is the way we can get better care and better access for either a rural part of this country or even an urban center. Of course, we need fair reimbursement and access in order to do that, and we need to make sure that we're part of now all of the discussions around value-based healthcare models. I think it's important to note that when you talk about licensure, and I heard the last panelist talk a great deal about the need for licensure and how that works. For those that may not be familiar, there's a great deal of licensure, or there's a great deal of government entities that are involved in how and what pharmacists are allowed to do. At the federal level, Congress can pass bills that would allow pharmacists to do certain things. Health and Human Services, of course, is able to work on and figure out what type of issues pharmacists are able to do. And then, of course, CMS, Center for Medicare and Medicaid Services, They will dictate whether pharmacists are recognized as non-physician providers, and that, of course, associates payment, which then commercial providers typically follow. At the state level, governors in some cases are able to waive different regulations. State legislatures and state boards of pharmacy, depending on the state, share responsibility for the scope that pharmacists and pharmacy techs are allowed to have in individual states. So unfortunately, there's not one answer, whereas if this entity passes a bill or this governor signs a bill, then all of a sudden pharmacists are able to do something in all 50 states. Unfortunately, we usually have to solve for issues at the federal level and then also have to solve in the 50 different states. COVID-19 testing is the best example. The Secretary of HHS, Alex Azar, granted authority under the PrEP Act for the pandemic about 2 months ago, saying that pharmacists can order and conduct COVID-19 tests. Even though he said that, that still only allowed us to do that in roughly 22 states. Another almost 30 states still required changes by either the governor, the state legislature, or the Board of Pharmacy. So our team in U.S. government relations with Walgreens worked around the clock to change laws on an emergency basis to also then allow pharmacists to do what the Secretary of HHS said was they should be able to do, but to do it in all states. As of right now, we Walgreens are ordering and conducting COVID-19 tests in 48 different states. We're still working through an issue in Hawaii, and the state of North Dakota actually has laws against chain pharmacies being able to have a pharmacy in those states, so we're not able to be in North Dakota either. But hopefully this just gives you a sense of a great deal of regulatory and legislative challenges in terms of how we are governed. What else do we need? I talked about this a little bit before, but we need information technology to run new models of care. We need back-end technology. All of this allows for medication adherence, medication synchronization, point-of-care testing, data tracking, etc. We've spent a lot of money as a company in the last couple of years to build this back end out. I would probably argue it should have been done sooner. We're not quite where we should be relative to the technology strides that have been made in other sectors and in other industries, but we did realize that it needed to happen, and now we're trying to devote the appropriate resources. I'm not going to spend a ton of time on reimbursement today and how much we get paid and why, but I will revisit this at the end as it relates back to how we're able to conduct COVID tests. And then lastly, again, I think you all are very familiar with all of the different pay models, whether it's an ACO or it's a value-based agreement. Those are all things that we're now doing with employers, with health plans, with hospitals, with health systems, to make sure that when you talk about a physician relationship to the patient, or a hospital physician-patient relationship, we're also talking about a pharmacist being embedded. That can be a pharmacist inside of a doctor's office. That can be a pharmacist inside of a hospital setting. That can be a pharmacist inside of a healthcare setting. More and more now, you're seeing that pharmacy students are coming out and they're picking to either go to a retail or independent pharmacy or work for a hospital or a healthcare system. And we encourage that. We believe that the care cannot be delivered at the most efficient basis unless a pharmacist is part of that equation, in light of what we do with medications and adherence and everything else. I wanted to share an announcement we made recently, and I think part of the announcement is to show that we're not just about pharmacists. Pharmacists can't do it all. Pharmacists are not medical doctors. In addition, we had tried a strategy in the last several years focused on clinics that were staffed with nurse practitioners. We have now largely moved away from that. Walgreens has only 250 clinics, but all of them are actually run by a health system depending on the area of the country. In Illinois, for example, Advocate runs all the Walgreens clinics. Those clinics are staffed with nurse practitioners. There is care that those nurse practitioners are able to deliver, and we believe it's important. However, with this announcement, with Village MD, we are actually now believing that the real goal to the future of how healthcare can be delivered in a retail setting is through primary care with a pharmacy model. And again, this gets back to a nurse practitioner can do cuts and scrapes, can do flu tests, can do a handful of different procedures, but they're typically one time. They're episodic. It's not chronic care management. We believe that the future of delivering healthcare at the retail setting is with a physician. And that physician can focus on long-term better health outcomes, which will of course reduce costs, but it will also provide for a differentiated patient experience. You all are probably very aware of the fact that a patient that has a chronic condition typically sees their pharmacist a dozen times at least a year. It's usually up to 24 depending on how many medicines they're on. How many times do they typically see their primary care physician? Probably a third of that or a fourth of that. In addition, it's much easier to go to one of our 9,000 locations if a primary care doc is present. Now, of course, this announcement is that we will be opening up these Village MD arrangements in 500 to 700 different Walgreens over the next 5 years. We hope to actually expedite that and make it even faster based on the success, but initially we're looking to do it in roughly 10% of our locations. A couple of just news article or news clippings from the announcement and what we believe in addition to the arrangement, we're investing in Village MD, showing that we're really interested in this future of healthcare. The last thing I would mention to wrap up here, and hopefully we can take a couple of questions, is that while we are currently able to do COVID tests, we're not able to be, right now we're being reimbursed for those tests by Health and Human Services. They are paying us roughly $70 to $80 per test for all individuals that meet the criteria through our website and then come to the testing centers. What we're not able to do is bill Medicare for Medicare patients, Medicaid for state Medicaid patients, of course, and then also a commercial insurer. If you worked for Walgreens or you work for Concordia or you work for Caterpillar and you needed to get a COVID test, we don't have the ability to bill a private insurance company. And the argument is folks that have insurance should be able to get that COVID test and their insurance company should pay for it. If somebody's uninsured, HHS would continue to cover the cost of that test. But because Walgreens is not recognized as a non-physician provider under Medicare, we don't have that billing mechanism. Here are a couple of articles that show that the American Medical Association had initially been opposed to pharmacists being recognized as non-physician providers and doing some of the testing. When we pointed out that Walgreens alone has done 450,000 COVID tests, and we're extremely proud of that, that was a very strong indication to the AMA that they probably needed to figure out a better solution. Unless, of course, they believe there's enough doctors in this country to be doing more COVID tests, and they would clearly don't agree that that's the case. So we're working with Congressman Buddy Carter, who coincidentally is a pharmacist from Georgia, Chuck Grassley, senator from Iowa, and as well as a number of folks on the Senate Finance Committee, Ron Wyden, Sherrod Brown from Ohio. There are Democrats, there are Republicans that both agree with this. The challenge is figuring out the back-end billing mechanism for this, and that's what we've been going back and forth with CMS over. So you would think that because we're already doing COVID tests, we would be able to bill for them through CMS. We're not, and that's what this legislation would allow for. It would be another step towards allowing pharmacists to be doing more in the healthcare system. So I'll stop there, and I believe that was the last slide.
Yeah, thanks, Ed. So we're a little bit over time, but just real quick, there was one question that kind of relates to what you were just talking about. So is Walgreens working on scope of practice for delivering immunizations with the vaccine that's going to be coming online, hopefully in November, December, with emergency use authorization? And is that going to be tethered to CDC guidelines?
Great question, and obviously very timely. The answer is we have scope already to administer vaccines. The vaccine for COVID is in the same bucket essentially as the flu vaccine or immunization, which I would encourage all of you to get your flu shot, especially this year. The symptoms for flu and COVID are very similar. And so if you typically say, I don't need the flu shot, I'm tough, I'm young, or I just don't believe in it, I would argue this is absolutely the year to do it. But yes, we are also working with the administration, and the first vaccine that hopefully comes online, Dan, as you said, towards the end of this year, Walgreens, Walmart, and a handful of other pharmacies will be on the front lines, hopefully administering and delivering that vaccine as soon as it's ready.
Great. Thanks, Ed. And maybe if people have questions, you can put them in the chat, and Ed, if you have time, feel free to answer them there. So
I'd be happy to.